let's come to the third part of malignant liver tumor. We are just to talk about HCC. The contents include diagnosis, treatment, and future. First, let's talk about diagnosis. Diagnosis include symptoms, signs, and examinations. We have mentioned symptoms and signs in the second part of the lesson, and examinations include determination of AFP, hemoenzymology, and other tumor markers, ultrasonography, CT scan, MRI, selective static or hepatic arteriography, radioisotopic hepatic scanning, and the last one is needle aspiration cytology for liver puncture. We should know it is an invasive examination. Imaging techniques are very important to detect HCC at an earlier, potentially curable stage. The standard imaging techniques are contrast-enhanced ultrasonography, contrast-enhanced CT, and MRI. We can see from the picture that typical vascular patterns on contrast-enhanced CT are enhancement on the arterial phase of imaging. It's on the right side. This is a wash-in phenomenon, and hypointensity compared with the surrounding liver in the venous phase is wash-out phenomenon on the left of the picture. Differential diagnosis includes cirrhosis, but not malignant tumor, and secondary liver tumor, or liver abscess, and hepatic echinococosis, or benign liver tumor, or tumors of adjacent organs near the liver, such as the right kidney tumor, or hepatic fracture of the colon, or stomach, or pancreas. Then we come to treatment of HCC. Let's talk about the principles of treatment. First, early detection, early diagnosis, and early treatment, and combined therapy according to different stages of disease. They are the key to improve the curative effect. And second, early surgical resection is most effective treatment for such kind of patient. And third one, for unresectable middle and advanced stage liver cancer, transcatheter arterial chemoembolization, abbreviated as TACE, and ablation therapy, chemotherapy, radiotherapy, traditional Chinese medicine, they can be considered. Sometimes tumors can be downstaged, and the patient can have chances of operation. Their survival can be prolonged. When we consider surgical treatment, we should understand, first, surgery is the first choice and most effective method. Second, for patients without severe cirrhosis, without obvious jaundice, ascites, or distant metastasis, and patient with good liver function and compensation, and patient with normal heart, lung, and kidney function, surgical exploration or hepatectomy can be performed. And third, appropriate hepatectomy management depends on the patient's general condition, the degree of cirrhosis, the size and the location of the tumor, and the compensatory function of the liver. Sometimes we should consider other methods, such as TACE or ablation. For unresectable liver cancer, local ablation or TACE can be used according to the specific situation. TACE can reduce the tumor size, and some patients get a chance of second-stage surgical resection, and supraselective hepatic arteriography through femoral artery incubation and TACE can be performed repeatedly. Let's talk about systemic treatment. It is very also important for patients in advanced stage. Systemic treatment often include, first, chemotherapy. The most famous protocol is 4-FOX4 protocol. Then, target therapy with sorafenib, lenvatinib, regorafenib is also proved useful in some patients. The first two drugs are first-line therapy, and the last one is second-line therapy. And immunocheckpoint inhibitors, such as anti-PD-1 or anti-PD-L1, are very new. They are even not written in the textbook, but they are appeared in magazines. Sometimes, when they are used together with target therapy drugs, the effect is very obvious, and the patient survival can be prolonged. Other treatments are antiviral therapy should be carried out through the whole process of treatment in patients with hepatitis B virus infection. And for hepatitis C virus infection, direct antiviral drugs or interferon alpha combined with ribavirin antiviral therapy are recommended. We also need hepatoprotective therapy and symptomatic and supportive treatments such as active analgesia, anemia correction, hypoalbuminemia correction, nutritional strengthening, treatment of complications. They are also should be considered. And last, sometimes we can consider traditional Chinese medicine, and they can be useful. For some patients, liver transplantation is also a good choice. The left picture is illustration of the operation. Hepatic vein, portal vein, hepatic artery, and bile ducts are all anastomosed again. The right picture shows the excised liver and the new liver together. They look really different. When we talk about liver transplantation, we should have some basic knowledge. First, liver transplantation has increasingly become an effective treatment for end-stage liver disease. There are international standards for indications of liver transplantation for liver cancer. Most popular criteria are Milan criteria and UCSF criteria. And for patients following liver transplantation, they must take some immunosuppressant every day, the whole life. This is the 2018 EASL clinical practice guidelines and modified Barcelona staging system and treatment strategy. We know this from this complicated picture that patients in different stages do have different treatments. So, what is waiting for us in the future? We have some ideas. First, we can improve surgical technology. Now we can use Da Vinci robot surgery, and we can do preoperative portal vein embolization, and we also can do LPPS, that is associating liver patrician and portal vein ligation for staged hepatectomy. And we also have some new technologies such as three-dimensional visualization technology. And the last one, we can have rapid development of pharmacology that will bring us new drugs, especially drugs for targeted therapy and new immuno checkpoint inhibitors. That all will help us in the future. And this is the end of the lesson. Thank you.